Hey guys, welcome back to the Phone Frat podcast. Happy holidays from the entire team. Hopefully you
Hey,
have
you
some
didn't do
time
accountant.
What?
You didn't do accountant that time. That was weird.
I know. All right, let's do it again. Ready? Here we go.
Yeah.
3, 2, 1. Hey guys, welcome back to the Phone Frat podcast. Tyler and Sam, we're talking all about thyroids,
Mhm,
and actually not me, Sam and Brian are.
mhm,
And we recorded an intro just now, and then we were talking about it afterwards, and we're like, God, this is so complicated. How do we make
mhm,
this simpler? And then we're like, you know what? Let's just re-record it because you have to have some sort of like mental model of how all this stuff works
mhm,
going into this conversation. And you guys talked about it, how we don't get a lot of this education. It's only a couple of pages in your paramedic textbook in the
mhm,
beginning. And as I was going through this and I was reading, and I'm like, God, I don't know a lot about this. And so I was just asking Sam, I'm like, okay, so tell me where the holes in my bucket are in the understanding. You have the pituitary gland, and
mhm.
then that releases thyroid stimulating hormone,
Yep,
which is a hormone that stimulates the thyroid to release T4. And so I think of the T because it's from the thyroid. I don't know
that's
why we
good.
skipped to 4. Is there a reason why we say 4?
Yeah, so it releases T4 and T3. So that's the first confusing part is when you start to read about the thyroid. You're like it'll say thyroid hormone is released, and then you'll read a next paragraph and it'll say, and so this T4 and T3 T4 slash T3, and you're like, is that thyroid hormone? It seems like there's two things now. Am I reading about one thing or two things?
Yeah, so what's the 3 and the 4?
It's how many iodines are attached to essentially this thyroid hormone. So there's a thyroid hormone, and there's a version of it that has 4 iodines on it, and there's a version of it that has 3 iodines on it, and they
Okay.
call that collectively thyroid hormone. The thyroid releases both of them. It's about an 80, 85, 15, 20-ish ratio where, yeah, probably about 80, 85% of it is T4. That's the more inactive form. It's not nearly as potent. But T3, very active. That's the stuff that causes the actual effect you think of with thyroid hormone. And so it's like the active form. And so what happens is that T4 gets dragged into a cell when it needs to.
Hold on. We gotta. I just want to slow down a little bit.
All right, all right, all right. We're
You,
gonna
you gotta
slow
you gotta
down on
keep
this.
up with my brain here, man. Or I gotta keep up with yours, I should say. All right. So you release T3 and T4. The
Yep,
majority of it is T4.
yep,
The only reason we're saying 3 and 4 is because of how many iodines are on it.
yep.
All right. So that gets circulated throughout your blood. It's
Mhm,
going throughout, it's meeting different cells. And then once T4 gets into a cell, it gets converted to T3.
mhm,
And then that's what starts the whole cascade of
mhm,
making G proteins, transcription,
mhm.
and ultimately it's increasing the amount of ATP available in that cell.
Yeah, they're just expending energy like crazy. So when that T3 comes in, which, yeah, T4 can come in or T3 can enter directly. And if T4 comes in, it just gets turned into T3. So essentially, you're whatever's causing the process to occur, the stimulation, it's from the T3 mostly. So that comes in, and yeah, it basically has this one mechanism where it goes to the nucleus that changes how the cell pretty much expresses itself, and that can do a bunch of long-term things like sensitize the cell long term, and it's more sensitive to beta stimulation and stuff like that. Or it can cause acute changes where it's going to stimulate the cell right now.
All right, so this bad boy gets in there, starts
Mhm,
changing up some of the transcriptions. Does it actually
mhm,
increase the amount of beta receptors on the
mhm.
cell?
Yeah, yeah. So when
Does.
it goes in and it interacts with the actual nucleus, it can take messages from that nucleus and then bring it to like the cell membrane, and that cell membrane can create more beta receptors. Or there's a bunch of different ones. If you guys look at the reference that I had in there for, I think thyroid storm, it was either thyroid storm or Graves' disease. I can't remember which one, but it lists like maybe 8 mechanisms for sensitization through interacting with the nucleus, and then it also goes into essentially how this thing directly stimulates those cells as well.
So you wouldn't want a ton of T4 and T3 and T4 flowing out through your body because you imagine there's a cell, you can only fit so many beta receptors on that bad
Mhm.
boy, right? So
Yeah.
if you had a situation where your body was continuously stimulating that thyroid to release T3 and T4, you would probably have a situation where some of that T4 is and T3 is coming back, and the thyroid seeing it and it's going, "Hey, why aren't you using all of this?"
Mhm.
And then that would provide a negative feedback system to tell it to slow down. Is that right?
Yeah, so the thyroid, I don't know if the thyroid can sense it in the graphs that I've looked at. It's just the pituitary and the hypothalamus that sense excess T4, which if it's not getting utilized by the body, it just builds up. And then, oh, hey, here's all this T4 floating around that never got used, never got transferred into the T3. And then the hypothalamus and the pituitary see that and they stop sending thyroid stimulate like the pituitary stops sending thyroid stimulating hormone to the thyroid, and then further up the hypothalamus stops sending the thyrotropin releasing hormone to the pituitary, or the TRH. So it stops the first two steps so that the thyroid never gets stimulated. And then once that free T4 falls, because the body's using it up over time, then that negative feedback mechanism stops. And then the gates are, the chains are taken off of the hypothalamus and pituitary, and they start stimulating the thyroid to do the whole thing over again.
It's interesting, dude, because it reminds me of like all the steps that are necessary for somebody to hit like a nuclear bomb button.
Sure.
Like
Yeah.
there's like the
Double,
decision has to
triple
be
safe
made
checks.
here. What's
Mhm.
that?
Double, triple safe. Oh, like the two keys. Is that what you're talking about?
Well, kind of, yeah, but I'm talking about how, like, somebody's gotta make that decision,
Mm,
and then that's gotta get passed on to this person who okays it, and then
mhm.
that's gotta go and then eventually it goes down to the guy sitting in a shack in Alaska that's got the button,
Yeah.
and hits it. But there's all of these things like that, and it's like with the clotting cascade too. Like there's all these events that have to occur for one event to happen. And
Mhm,
it's fascinating how that happens. And we were just talking. I was like, all right, so let's just say you remove your thyroid. Like people get thyroid cancer. I don't
mhm,
know if they have to remove a goiter or something like that. They got to
mhm,
probably take off the entire thyroid, right? You
mhm.
can't
Yeah.
just carve off what you don't need and
If
leave the
it's
rest.
if it's not, I don't know if they ever take out nodules, because you can have this multinodal toxic thing where it grows in these big chunks. I don't know if they ever just take off parts of it. Most thyroidectomies are complete, though.
Like a one-winged butterfly.
Yeah, I don't know if they ever do that or not, because I think once it'll grow, it'll grow. I don't know a lot about thyroidectomies, but I put some nasty pictures of goiters in the in the blog.
But if somebody didn't have that,
Mhm.
then they would just have to take T4, T3, T4, right?
Yeah, levothyroxine, and anytime we hear of somebody being on levothyroxine, or the synthroid, synthetic thyroid hormone, I think it's only T4. You can take. I mentioned in the blog that you can like intravenously give T4 and T3. The T4 is levothyroxine, and then I'm going to try to say this word off the bat. It's triiodothyronine, which is T3. Triiodothyronine. I spelt it phonetically in the blog because I was having such a problem with it. So yeah, that's the T3. That's not as common to give intravenous because it's pretty potent.
Cool. All right. I'm not going to spoil any more of it, but using that mental model, go into this podcast and then go read the blog, or read the blog and then listen to this. And maybe we'll start to understand the system a little bit better. Sam has volunteered to write the next chapter for the paramedic textbook on thyroid disorders. So you
Eh.
can expect the foam frat paramedic curriculum. That'd be awesome. We should do a
Oh, that
foam
would be
frat
cool. Oh, and
textbook.
before we get the episode started, the if you guys checked last time, and the which one did we sell
Hemodynamic.
out of? The
Hemodynamic.
hemodynamic card. Yeah, hemodynamic card is back on sale now, and let us know those the 3 packs that we were selling went like hotcakes. We sold, I didn't think we would sell
I
more
think we
than
should sell
1,000.
hotcakes, honestly.
Yeah. And, they we sold, I think I did an order of 1,000 to do those, and it's crazy to think that we sold out of those things, especially, and then people were ordering the hemodynamics one on top of it. So we sold out of that one, but they're back in now, and let us know if you guys want to continue to see us sell those 3 packs, because we weren't gonna continue those, but maybe we will.
Mhm.
We'll see.
Awesome. Sounds good. All right, let's roll the episode.
Welcome
Let's do
back, man. You ready to get started on some endocrine stuff after working an overnight?
Yeah, let's do it.
So,
Feeling great.
yeah, this is not everybody's favorite topic before we started the podcast. Tyler and I. That's tough to
Eh,
break when I'm with somebody else on here. So, Brian and I were talking about textbooks, and so we both broke open a textbook, and we were like, I wonder how much page real estate endocrine is taken up. And so in my old one, which it's always funny to see who learned out of what books. I had this one. What is this one on Mosby's, updated for the 2005 ECG guidelines. So in here it was page, let's see, thyroid issues cover page 863 to some of 864. So there is like one paragraph on thyroid toxicosis and then one paragraph on like myxedema, coma and stuff. So we didn't have to learn that much about this in paramedic school because we like just don't do a lot with these hormones and stuff. Like most of the endocrine chapter is all diabetes, which kind of makes sense, you know?
Yeah, and I think that's it, that's sort of the typical theme of, you know, most paramedic education in general. It's
Mm,
incredibly, sort of skim the top of it,
mhm,
and hopefully you've heard of it. But I think this is another one of those topics that is simply not talked about, and there's for a couple of reasons. It's rare, right? So
mm,
it's usually not on people's radar. And I think the thing that's interesting with this is if you've been in medicine, whether it's emergency medicine, critical care, or EMS for any length of time, and you really sort of sit back and sort of go through some patients that you really question, you probably didn't think of hyper or hypothyroidism initially on
mhm.
your diagnosis. But I would hazard to say that this is probably something, though incredibly rare, that we probably should keep in the back of our minds.
Do you remember that time that I sat in on your myxedema coma talk and I called you afterwards and I was like, dude,
Oh yeah,
I
yeah,
think
yeah. That was the
I
first time
think
I
I
heard
missed
it too.
a myxedema coma patient like last year or the year before. I can't remember when that was. And it was all the classic signs and symptoms. This patient wasn't responding to like the boatload of every pressor that we had them on. They weren't responding to calciums or like anything. And the patient was cold and they were going through glucose. And I was like, what is going on with this patient? And you're right. Wasn't on my differentials. The endocrine didn't even come into my brain. And I remember calling you like, dude, I think that's what it was. And I felt really silly afterwards. And then I found some solace in that like nobody else thought of it either. Not that that's a good excuse, but it's like if somebody else would have been like, well, you idiot, that's a myxedema coma
And,
patient, then I would have felt really bad.
and
But it's true, yeah.
it's funny since I've started teaching this, you see how often like a TSH is ordered on patients, right?
Mhm,
But I think there's a line here of where these patients that come in incredibly sick,
mhm,
and we sort of lose track of, sort of casting a big net where it's like, hey, they're probably septic, or they're an overdose, or something else is going on, and then routine labs are ordered, and then for some reason a thyroid
mhm.
panel just isn't on your mind, and then they're admitted. You look at them a couple days later and you see that, oh, they had hypothyroidism, as well as this profound sepsis or an MI, or whatever it is. And I think it's very important, is even pre-hospital providers, that you keep that differential to say like, hey, not all of this is really adding up.
Mhm.
And that's really where I got interested in this. I remember, years ago, a friend of mine told me a case, and it was hyperthyroidism, and he was like, "I that wasn't even
Mhm.
something I considered."
Yeah, I think it might be. Not only is there not a lot in the textbooks or anything, so we're not expected to get, there's not on the exams in school and stuff. But I think the other thing is too, a lot of the diseases that we know stuff a lot about, at least in EMS, is stuff that we carry medication that kind of mimics the process. And
Mhm.
so that's why I think, the last one, I bet you didn't know you're signing up for endocrine podcast when we started talking about this, but with adrenal insufficiency that we talked about last time, it's a little bit more familiar because it's like,
Mhm.
okay, androgens, and then you have like the different layers, and we're talking about pressors, and we're talking about vasopressin and the RAS, and it's like those things more familiar. Then you start thinking about some of these thyroid axes of mechanisms and stuff, and you're like, well,
Yeah,
kind of remember that, It's like
it's just not
we don't
something
have
that's
to think
there.
about it very often, at least in EMS. So I
Absolutely.
was gonna show kind of the mechanism. So just to get us started, because Brian and I both were like, let's just start like real basic. So here's a thyroid. So like it's not very easy to see in there, but it's back there. It's on the front of the neck. It's on the cricoid cartilage, thyroid cartilage up above, cricoid cartilage, and then here's a view from underneath. If you guys aren't watching the YouTube, make sure you go subscribe to the YouTube channel because we're gonna be throwing up some pictures. But from underneath, and you can kind of see it wraps around the trachea. It can even wrap around like part of the esophagus and stuff. And then where is the other one? So the kind of like where the thyroid is and stuff. Here's a goiter. And so sometimes you see goiters. I had just this one up on here, so obviously everybody's seen a goiter where it's coming off the front. But I just had that picture in there. I told Brian like everybody's gonna want to see the most ridiculous goiter on the face of the planet, and you guys who aren't watching this, you won't know, but this goiter hanging off the front of this person's neck is the size of their head, or
Yeah.
maybe bigger. You know, so they can get totally out of control, and you can get a goiter from hyper or hypothyroidism. So it's kind of crazy. And I didn't. Oh yeah, I did put the picture in here. I was reading that because you always, those pictures that we were just looking at, you would imagine that you can see everything that goiter is touching. It seems like it just hangs off the front of the neck, but it grows in and
Mhm.
can start to strangle your trachea. You can have blood flow issues with your carotid
Yeah, you can
and
develop
jugular veins, arteries, and
SVC
then
syndrome.
yeah, it can go into the sternum. So I had found this picture, and looking at the lower left, I put this one in the blog. Looking at this lower left one, that B, you see C is the aortic arch, and then B, if you're looking at this lower left picture, B is the thyroid, or is the goiter.
Mhm.
And so it like creeped down next to the spine, like behind the sternum, which I thought was crazy. Like think about it's like coming in contact with everything you don't want something weird to touch, like your
Yeah,
aorta. It's
all those
touching
great
your
vessels.
yeah, it's touching your trachea, your esophagus. It's weird when these things start to grow out of control. That would really make me nervous knowing something was like growing into my chest.
Yeah, and you wonder how
Uh,
long that one went without
yeah, yeah.
medical attention.
Yeah, no kidding. And in some of the third world countries, the reason that they have these goiters is just lack of iodide. And so that's
Mhm.
when you guys see like salt, like iodized salt. That's why, is because these patients in other countries, it's not common here at all because we get a ton of iodide in our diets. We get a ton of everything in our diets. But in other countries, they don't have this iodized salts, and they don't get it through their diet, so they can get these big goiters from not taking in iodide. And so I found that crazy. I had never known why that was a thing, like iodized salt. I knew it had something to do with iodine or whatever, but I'm like, oh,
Yeah,
who
like
knows
that
why they do that?
protein are, incredibly important for the thyroid,
Yeah.
which, that's I think that's another thing. You have some of these malnourished people or, it's again something you wanna really think about.
Yeah. So then, so anatomy, kind of like know where it is. We know where these goiters form and stuff. People don't have to have a goiter, but they certainly can in both high and low. And then this was the mechanism that I think most people are curious about. So this is the hypothalamus pituitary thyroid axis, and so it's a lot like our adrenal stuff from before, where it goes hypothalamus pituitary, and then it goes down to the target organ, which in last time was the adrenal. This time it's the thyroid. And so thyrotropin, and these are, just remember there's one that goes, from top to middle, and then one from middle to bottom. TRH, thyrotropin releasing hormone, goes from hypothalamus to pituitary, so it does that first step. And then the major one people think about is TSH, which is thyroid stimulating hormone. So the interesting thing about this is, so that TSH goes in, and it makes this thyroid release T3 and T4. All right, so I'll just show you guys those real quick, because when we say thyroid hormone, that's what we mean by thyroid hormone. It's kind of confusing because people say like, well, which one is thyroid hormone? Is it T3? Is it T4? Because it'll say releases thyroid hormone, and then you have these two things. It sounds singular, but then it sounds like there's two of them. And so this is the difference right here. It's really the same thing, but it's just a little bit different. So I'm showing on the screen here T3 and T4. Um, T4 just has an extra iodine on it, and the body can strip that iodine off and turn it into T3. So maybe Brian, you can touch on like what is the difference between this T3, T4? Like it goes out into the body. Like why do we make different amounts? Because most of the stuff that comes out is T4, right?
Yeah, so the body, or not the body, but the thyroid releases both T4 and T3. Now, T4 is the inactive form of thyroid hormone. T3 is the active form. Now, you release much more T4 than you do T3. So it's about an 80-20 mix where 80% of the release is T4, 20% is T3. So again, T3 is the active form of thyroid hormone. And what happens is when T4 sort of goes out into the body cells, that's when it's converted into T3.
Mm,
Um, but T3 is actually much more powerful, even though it's a smaller amount.
mm.
And that's pretty much where your hormones are coming into, and then it continues with this negative feedback loop that essentially continues to go around and around and around.
Yeah, I'll show people that negative feedback loop again. So pretty much, well, I guess I'll describe it first. So what Brian was saying, like, think about how that works. Let's say the body cell is using up all this active form. So you have T4 floating around, it goes into a cell, and the cell's like, I want to use this thing. Let's make it into T3. So it strips off that one iodine through an enzyme, and then boom, you got this active T3. Well, that means that it's like you're siphoning off of that T4. So if you're using a ton of this stuff, like naturally the T4 that you have sitting around is going to be reduced.
Mhm.
And so that comes right back to our negative feedback mechanism. We'll put it back up here. As you have an excess of T4, look at what it does. It, goes up and shuts off the pituitary, shuts off the hypothalamus, and says, "Hey, clearly this stuff isn't getting used up. We're not using T3, so it's not pulling from T4." And then if that's building up, then don't send any more thyroid stimulating hormone. It's that simple. If we have excess, don't make more. And so that's how a lot of these negative feedback. It's exactly how all these negative feedback mechanisms work. It's like you got an excess, well then stop making more. So there's different things. So um, when we think about what goes wrong with the thyroid, everybody's heard, oh, I have a fast or a slow metabolism or whatever, or I have hyper or hypothyroidism. So I thought that we would start. I have I'm gonna put this graph up. I found these, and different reports show different numbers. I don't know if these are like the cement numbers, but I tried to find stuff that was American based, to get a sample of the population. And so this is what I found. So most common for hypothyroid is Hashimoto's thyroiditis. And then most common cause for the hyperthyroidism was Graves' disease, and you can see the numbers. So it was like they're not common. Males and females, massively more affected than males in this disease. It's like 7 to 8 to 1 or something like that. Men like less than 1 in 1,000. Females like 3.5 in 1,000 for Hashimoto's thyroiditis, and then myxedema coma. So there's like the thing that causes it, you have the actual disease, and then you have like the bad thing that happens. So you don't just like catch myxedema coma, you get something that gives you hypothyroidism, like myxedema, I'm sorry, like Hashimoto's thyroiditis. And that thing makes the thyroid not work. And then when the thyroid doesn't work, you get this condition, this state of being of hypothyroidism called myxedema coma. Did I pretty much get that right? Like you get the disease and that causes this really bad.
Yeah, so with these, and with both, even though we're focusing right now on hypothyroidism, but both with hypothyroidism and hyperthyroidism, what we're talking about is these extreme manifestations of the two. And I
Mm,
think, we've all come in patients that are on either hypo or hyperthyroidism. But when
mm.
we're talking about myxedema coma or Graves' disease, or I'm sorry, myxedema coma or
Thyroid storm.
thyroid storm, these are the extreme manifestations. And while we're focusing on myxedema coma, I think myxedema coma is a huge misnomer because most of these patients don't present in a coma.
Mhm,
They have alterations in their mentation. They may have a depressed GCS, but they're
mhm,
not in a full-fledged coma. So
mm,
that's the other thing that makes this very difficult to sort of keep on your differential.
mm.
And the fact that they're with both of these diseases, there's always a trigger. So MI, stroke, diabetes, any type of trauma, these can all precipitate into these extreme manifestations, um, which is important why you need to keep that on your differential, because I think you'll go down a pathway of, Sam's case earlier, where you're treating this patient for sepsis, um, or some other condition, and it's just really not on your radar.
Yeah, I have this like general graph I'm trying to find right now about hyper and hypothyroid as it concerns like the different organ systems. And so I thought we'd kind of put those up now, and then when we talk about hyper as well. So here was the metabolic. Actually, I'll put this up first. So this is a cool way of thinking about these metabolic, I mean these endocrine conditions. And with the thyroid, they say like the three M's. So metabolism, movement, and then mentation, the three M's of the thyroid. So mentation is, is key. If it's low, the mentation also goes low. The metabolism goes low. And then the movement, in other words, like strength goes low, right? So here was the one, where is it? This was the cardiovascular stuff, which obviously we'd want to know. So if we look at hypothyroid, like low cardiac output, a low heart rate, a low blood pressure generally in later stages. But one thing that's really interesting was the vasoconstriction. So it's like they get everything like everything it fits the rule, right?
Mhm.
Everything is the heart rate's going slow. It's not beating very hard. The mental status kind of sucks. Everything is very depressed. But then the afterload is high, which is a weird thing with
Yeah.
this, partially compensatory and thyroid hormone not being there, not inhibiting that vasoconstriction. So I found that to be a really interesting thing with this. So that was the cardiac stuff. So cardiac, everything kind of depresses, and then with the brain, mental status. This was interesting. Early signs, variable mental status changes may include delirium and hallucinations.
Mhm.
Typical is just a decreased LOC, and then late they can go into that coma. But one thing I found, I'd never heard of this before, researching this, was something called myxedema madness. And it was like these weird delusions and hallucinations that they can get. And so they can actually, like you were saying, like they don't have to be in this coma on presentation. They could just be acting really strange and
Yeah.
seeing, hearing things that aren't there.
And I think with that is that's very, very common. They have some form of, central nervous system involvement where they'll have agitation,
Mhm.
delirium, or even, just frank coma. But again, you don't want to put that with it, because it's
Mm.
not the most common.
Yeah.
I think when you're thinking about these sort of disease subsets, is the first thing you always want to think about is, especially in hypothyroidism, is it's usually a female,
Mhm.
and it's typically over the age of 60,
Mhm.
for this severe hypothyroidism, and then they're always cold, which is fairly common. I always think of my grandmother. She always complained of being cold, even if
Mhm.
it was 98 degrees outside.
Yeah.
um, and then they have hypotension, hypoxia, hypothermia, bradycardia, and this can sort of lead you astray, thinking, hey, there's something else going on, whether it's an overdose.
Mhm.
And the other thing that's interesting with uh, decompensated hypothyroidism is most cases occur in the winter.
Mhm.
So that's the other thing that you sort of think, okay, hey, this is sort of their natural progression, and it's some type of environmental issue coupled with something else, and
Mhm.
it's actually just their thyroid.
Yeah. Yeah, that was the last thing that I put up there. I didn't draw a mention to this while you were talking. I didn't want to interrupt you, but I tossed this one up where, yeah, temp was a big thing. And then obviously the just the regular basal metabolic rate being slow. And then it's a metabolism thing. So I don't think that anybody's like gonna not check a glucose in somebody that seems altered or weird, but that's another thing that could lead you down that road, where if you're just seeing like everything just kind of generally seems depressed. This thyroid is this thing that affects huge processes. And that was one interesting thing about thyroid hormone, is that it really goes every cell in the body is
Mhm.
affected by this. So just the general metabolism, our general strength of just about everything, and our, if you go back to our three M's, we covered the metabolism, the movement, and then everything about this altered mentation stuff, where they start to go down that road. The I think there was one other thing that I was going to bring up with the hypo, but I think we covered this one pretty well. So this was the neurological stuff. So altered mentation trending towards low unless they have something weird. And then we talked about the metabolism, low temperature, low sugar. And then the last one was all these cardiovascular signs where even though they have that vasoconstriction, everything else kind of seems to suck. Low cardiac output, low blood pressure, low heart rate. It wouldn't be very applicable to us to know this because this would be more of like a subacute phase. But they say those hypothyroid patients will have diastolic hypertension
Mhm.
because of that increase in afterload. And so they'll maintain a very high diastolic pressure and the systolic might be kind of normal. So they have like narrow pulse pressures. But we probably wouldn't see them in that stage. But it is something to note if you look this up and you say like, oh no, hypothyroid is associated with hypertension. Not when they get really sick. Like that's like you go to your doctor's office and they're like, wonder why your diastolic is so high. Let me feel your neck. Like that's that kind of like we're not talking
Mhm.
about like here we're at the low cardiac output point where there's not physically enough blood moving forward per minute.
Yeah, and I think the other thing, just to touch on this real quick, is going back to the podcast we did a couple weeks ago, is a lot of these patients may present with, a component of adrenal insufficiency as well.
Mhm.
So you'll see like that refractory hypoglycemia, and you'll see them send a cortisol level, to sort of cover their bases. But
Mhm.
that's something to also consider, that this stuff coexists frequently.
Yeah, and that was one good point that if you guys haven't listened to that adrenal one, go back and you'll see how these two things are definitely correlated and how that thyroid can affect it. That is a added level of complexity to adrenal stuff is these when you have big control mechanisms like hypothalamus and pituitary. It's like if something goes wrong or haywire or that one, pituitary especially affects a couple things and it gets diseased, it's like all of a sudden everything goes to crap. So, but learning about the individual diseases is kind of cool first. Um, then the hyperthyroidism, right? So I'll put this back up where we showed kind of the incidence. And so Graves' disease, just like Hashimoto's was this thing where that's the disease and then it causes the myxedema coma. Graves is the same thing where Graves disease, we see it 220 in 50, 20 or 50 to 100,000. And then thyroid storm has the incidence here about approximately 5 per 100,000 hospitalized actually get this thyroid storm. And this is what I was going to mention about the Hashimoto's and the I was waiting until we brought Graves' disease up. So here's something really interesting that I learned is that these are both autoimmune diseases, but I didn't know how Graves' disease actually stimulated the thyroid because we're moving over from everything's underactive, everything's very cold, slow, and just weak to now everything's like amped up like crazy. And I'm like, how does it? Because both of them are autoimmune. I'm thinking, how does it have these two different effects? And so the myxedema coma caused, if it was caused by something like Hashimoto's thyroiditis, that's an autoimmune disease, and it is attacking. This is an autoimmune disease. It's attacking yourself, right? So this Hashimoto's is attacking the thyroid with your immune system. Well, the Graves' disease does the same thing, but what's so weird about Graves' disease is that the antibodies that it makes stimulate the
The
thyroid. They
Yep.
they look just like thyroid stimulating hormones. They actually go in there and they cause it on overdrive. So I think that's super weird. It's like the immune system didn't get it right in either sense. Like I'm either going to attack this thing and it's going to in Hashimoto's it attacks it and it does what you'd think. It becomes inflamed and it starts not doing very well. And then but in Graves' disease, that those antibodies shaped a little bit differently just so happen to stimulate that thyroid, still make it big but send it into overdrive,
Mhm.
the opposite of what the immune system probably intended to do. It's such weird things.
And I think what's important with Graves' disease is, I want to say, like, it almost it's 75% of cases are related to Graves' disease. So
Mm,
hyperthyroidism and thyroid storm, Graves' disease is really the most common cause of that.
mm,
And it's not uncommon for us to see patients with a history of Graves' disease.
mm.
But again, our textbooks only put in about 2.5 pages.
Yeah, yeah. So this is a real like initial education. I feel like both of these with the endocrine stuff because we don't think about them much is more like a true refresher on the concept. So I'll do the same thing like what we did with the like what we did with the hypothyroid. So I'll bring the cardiac one up, and you guys can probably guess what this is by now. Increased cardiac output, increased heart rate, increased blood pressure, but they actually have low afterload because of that kind of paradoxical what we typically think about um, with the peripheral vascular systemic vascular resistance. So cardiac system mostly amped up like crazy. The neurological system, anxiety, nervousness, restlessness, the typical presentation for these hyperthyroidism patients, overstimulated.
Mhm.
But in late signs, so you don't want to get this confused with myxedema coma because you got to think about it like anybody who's, let's say that, we take our hearts and we give ourselves some epinephrine until things get real bad,
Yeah,
eventually we would become unstable, we would become comatose. So they're not like this patient that they get to this point where they're so overstimulated. Like, what are they going to do? Explode? No. Eventually, you're going so high, and then you have to come back down. So eventually, they will, come. Just like a VTAC. You get a stable VTAC patient. It's like, yeah, the heart's overstimulated for now, but eventually, this patient will regress into pulseless, VTAC.
yeah.
So kind of the same thinking. And then metabolism is super high, so they can't tolerate heat. Their metabolism is very fast. Um, Maybe some hyperglycemia, not super common. So they're kind of the mirror image of these hypo, which makes sense, obviously, right? Kind of the mirror image of these hypothyroid patients.
And if you see, patients with this sort of unexplained tachycardia, that's often a common, reason that they're going to send
Mhm.
a TSH level just to see what's going on. And the other thing is if they're hyperthermic, usually the tachycardia is sort of out of proportion with their hyperthermia. But
Mhm.
you can see these extreme manifestations where these patients are, incredibly febrile. But it's all about increased beta adrenergic activity and increased basal metabolic activity. So again, you'll see tachycardia, palpitations, tremors, diaphoresis, hyperglycemia, a high appetite with weight loss. And a lot of times this has been going on for a couple of weeks. And then, it sort of triggers over into that thyroid storm.
Yeah. So speaking, so kind of like moving into treatment a little bit, like let's start with I guess we started with hypothyroid stuff. So maybe we go back to treating that hypothyroid stuff. For them, it's like we can't give them like a normal patient. You go to the doctor, what are they going to prescribe? They're going to, in an emergent case or in the ER, if they're really bad, they can give intravenous T3 and T4, usually T4. But if they needed to, they can give T3. Well, that sounds like the perfect antidote, but we don't have that. So
No.
we're usually treating these patients on a more symptomatic basis where they require pressors, they require airway management and things like that. So, and warming these patients and not adding insult to injury with their hypothermia when that occurs, and checking their blood sugar to make sure it's not low. So the treatment is more based on the symptoms, but and so that I feel like the treatment of the hypothyroid, as long as you kind of know about it, isn't super complicated. You just might not have that stuff. I don't know. Do you feel like there's anything besides like pressors and like, is there anything else to this treatment of hypo?
Yeah, so your hypothyroidism treatment is exactly like you said. It's pre-hospitally and even in, the critical care transport world, I don't know of anyone who's carrying T3 or T4. The only thing that would sort of be there is steroids,
Mm-hmm.
from a stress dose perspective, and hey, they may have this adrenal insufficiency. But I think the thing you want to keep in your mind is where I could see this becoming very, very relevant is in the case that you have where, hey, you're not getting any response to anything.
Hmm.
And then say, hey, looking through their paperwork, I don't see any type of thyroid hormone being checked. This is something
Hmm.
that we may want to consider. Now, hyperthyroidism, on the other hand, a little bit more complicated in the treatment,
Hmm.
but there are some things that we can at least do, or you know we have available at least.
Yeah, there's a lot of treatments for this. So there's a bunch of stuff out there that will stop the conversion. Well, so emergent treatment for like these patients usually get beta blocked, right?
Mhm.
So if they're like crazy tachycardic, you just have to stop this beta stimulation essentially. But there's a ton of stuff out there that I mentioned in the blog. I'm trying to scroll to it right now. Besides the beta blockers, and you can use calcium channel blockers, but here it is. So thionamides, it's like we
Yep.
don't carry that stuff, but that's like the treatment of choice. And then they talk about like iodine solutions, glucocorticoids, bile acid sequestrants. All of those things, what they're doing is they're just stopping the conversion of T4 to T3, because if you can keep it in this like very non-potent kind of inactive-ish state and keep it from turning into the active form of it, you've essentially, stopped this process cold, not cold, like you don't want, not 100%, but you're addressing this root cause of it. And so the thionamide, which I've never personally administered ever, is something that we only have in the hospital. But all these different things that we see, it's all about stopping the conversion of that T4 to T3. And then other than that, pretty much we can just handle it kind of symptomatically, I suppose.
Yeah, the thing that's interesting is, starting with the beta blocker, like you said, is typically the preferred beta blocker is propanolol. Um, but the reason is that just does it best from decreasing the T4 to T3 conversion.
Hmm.
And any beta blocker will work. It's just that T4, or I'm sorry, that propanolol does it best.
Yeah.
So that's the one thing, and then what we're going through after that is really, as you said, the thionamides to block the synthesis, and then after that you go to block the release from the thyroid. And what's interesting about that is the order in which you give the medications. Granted, again, pre-hospitally and in transport, we're not doing this, but you'll give that blocking the release with iodine after about an hour of giving a thionamide.
And that would be good for treatment too. Like if like even just being aware of the process, that there is this process, and like, okay, they got to give this first, they got to give that, like then we move to a beta blocker or whatever. Just being aware that there is a process to this stuff,
Mhm.
that and you have three parts to it. You have the conversion, the release, and then the actual target organ end site where you could possibly help out with a beta block, in the emergent case or whatever. Just good to know that kind of thing. So these are things you could ask about before transport in the rare event that you get one of these patients. But I mean, there also is other things too. Patients can be sick with other stuff. There's a thing, in fact, sick is in the name. What is it called? It's called sick. You, oh man, what is it called? It's sick thyroid disease or something like that. I'm completely blanking on the name. Anyway, you can get essentially a decrease in thyroid activity from just being sick. Like if the patient is so thick, they can have, or so sick that I say so thick. If the
Yeah.
patient's so thick that they have thyroid issues, if the patient's so sick that they have thyroid issues, they can get what looks like hypothyroidism just from being that, severe sepsis or
Mhm.
whatever the case is. They can have these thyroid issues, and their free T4 levels, if they can be drawn or whatever, are going to be very low just from being very sick. And we talk about multiple organ failure all the time. Like these are endocrine organs that can be affected, and that can have a humongous impact on how that patient is responding to pressors. Because that's another crazy thing. I mean, you deeper you dive into this, and I mentioned this in a little bit in the blog, is that one of the roles, there's a ton of cardiovascular roles in these. So that's kind of like why you want to be, as a paramedic, at least you want to be kind of tuned into this, is like the cardiovascular stuff. The thyroid hormone is what sensitizes the heart to beta 1 activity. And so if you don't have this stuff, there's not a lot of beta activity flow, or things that would promote the response to this beta stimulation and create these beta 1 receptors. You're stuck with very few amount of beta receptors to try to stimulate with whatever kind of pressor that you're giving. So if you're having pressor unresponsiveness, or they've been trying to get the pressures up for a while and they're loading this patient up, and it's like, no, why isn't this working? Is it the acidosis? Does the patient need calcium? What else going on with the patient? Is this a hormonal issue? It could be.
And you can
So
see how you can go down these pathways of completely neglecting the thyroid, where you're
mhm.
just sort of you're throwing everything on it at it, and this is just not something you're considering.
Yeah. So another one to put on our differentials. But was there anything that we missed? I mean, kind of went over the anatomy and physiology, hyper
No,
treatment.
I
What?
think I think just in hyperthyroidism, again, we talked about it initially, but most of these patients are going to be tachycardic. And then you're also going to commonly see atrial fibrillation,
Yeah.
just because the thyroid hormone is, or the heart is very sensitive to that thyroid hormone. So you'll see a lot of atrial tachydysrhythmias. Um, but again, this is where you see somebody that sort of has an increased heart rate and increased basal metabolic activity. You may think it could be something not even on your radar, and this is one of those things that you probably want to think of. And I think this will, if you're passing this along in a report, this may, help somebody, go down the proper treatment pathways.
Yeah. Even if you don't have the tools to correct it right away,
Yeah.
even just the instinct of, man, this patient's had some, this type of history, or, they take Synthroid and we found them like this, or maybe they don't take Synthroid and we found them like this. Getting on that, just being aware of the disease processes and getting your thinking on that track, like, I couldn't conclude this pre-hospital, but I'm going to pass along this suspicion so that they can maybe draw a TSH level or a free T4 level or something in the hospital. That
Mhm.
might be what's wrong with this person, and everybody else might miss it if I don't have this suspicion. So even though, like I said, even though we don't have all the tools to fix this, sometimes it's about getting a diagnosis and handling it symptomatically as well. So,
Yeah.
well, man, should are we gonna take a break on the endocrine stuff now for a while?
I think we've covered most of it,
Yeah.
unless we
I
want
guess
to
we
go
didn't
into
do
DKA and
we
again.
didn't do well, yeah, I guess we have done DKA and HHS lately. Now we've done the myxedema coma and the thyroid storm, and then we did adrenal insufficiency last time. So I think
Yes,
that's gonna be good for a little
I think
bit.
we're good for a little bit.
I think we're good for a little bit. Well, I really appreciate you coming on, especially
Awesome. Thank
after
you.
working an overnight. I know you guys got your butts kicked, so
That's all right.
thanks again, man.
Thank you.